order. Welcome to meeting number 104 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to the standing orders. I'd like to make a few comments for the benefit of members. Please wait until I recognize you by name before speaking. For those participating by video conference, click on the microphone icon to activate your mic, and please mute yourself when you are not speaking. Interpretation for those on Zoom, you have the choice at the bottom of your screen of either floor, English, or French. For those in the room, you can use the earpiece and select the desired channel. A reminder that all comments should be addressed through the chair. Additionally, screenshots or taking photos of your screen is not permitted. In accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. Today's meeting is on the opioid epidemic and toxic drug crisis in Canada, pursuant to Standing Order 1082 and the motion adopted on January 20th, 2022. The committee is resuming this study. I would like to welcome our first panel of witnesses. Appearing as an individual, Dr. Rob Tanguay, addiction psychiatrist by video conference, representing the Association des Intervenants en Dépendance de Québec, Louis Letellier de Saint-Just, chairman of the board, representing the London Intercommunity Healthcare Centre, Dr. Andrea Serreta, lead physician, Safe Opioid Supply Program, representing Pain BC, Maria Hudspeth, executive director by video conference. Thank you for taking the time to appear today. You will each have up to 5 minutes for an opening statement. And I will, when you are 1 minute out, I will hold up a 1 minute for you to remind you how much time you have left. We're looking for good order and good government and discipline here today. So, that being said, Dr. Tanguay, you have the floor for 5 minutes, please.
Thank you. I'll try to keep it to my 5 minutes, as you'll make me anyways. I want to acknowledge I come from the traditional territories of the Peoples of Treaty 7 region here in Calgary and the Métis Nation of Alberta Region 3. I'd like to also acknowledge that I am also a person with lived experience as well as a physician. On April 10th, 2023, I lost my brother to addiction. He was found in his bathroom, dead on the floor. On September 2nd, 2021, I lost my best friend, Tom, to addiction. He was found in his kitchen alone. In April 3rd, 2021, I lost one of my best childhood friends, Brent, to addiction. And he was found in the basement of a house after a party. That's why I'm here. I think we all know why we're here, and that's because we're losing people every day. Last count was in the 20s. And we're losing preventable losses of life that we're all here to try to figure something out together. I want to really make sure that we distinct addiction from people who use drugs. We all use drugs. I'm currently drinking a coffee. Human civilization has been well known to use drugs. I am here because I'm a specialist in addiction, not a specialist in people who use drugs. As addiction, it is a disease. Nora Volkow and so many of us have been advocating for this model for so many years. It is a disease of the brain, no different than that of Parkinson's, schizophrenia, depression, anxiety. It is a disease, and it should be treated as such with appropriate health measures. For many of our most vulnerable, they are affected more by this disease. And right now we're seeing a shift in Alberta where as we've ramped up treatment, we see more and more loss to those who are living without a home, where now the majority of our deaths are occurring on the street rather than in private residences and other areas. And so we have to acknowledge our most vulnerable are often people living without shelter. These represent thousands and thousands of people across our country. When we start looking at those individuals, we understand that about half of those individuals have a lifetime prevalence of a traumatic brain injury, and about 1 in 4 or 1 in 5 have a moderate to severe brain injury that would normally require someone living in a home additional supports. And these individuals are resilient enough to be surviving on our streets. There's massive increase in substance use disorders, chronic pain, and mental illness in individuals living without a home, especially those who are unsheltered and not able to get into shelters. Where in recent BC data, 2 of every 3 report significant and severe mental health concerns. We know that these individuals need our support, and we know that they need help. And like any health disorder, the fact that anybody's debating whether or not we should treat it is not only shocking, it's discriminatory, racist, and stigmatizing. We would never debate whether or not we'll treat someone's cancer, whether or not we treat somebody's heart disease, but we will debate whether or not we'll treat somebody's addiction. And when we look at the best evidence at reducing death from somebody with an opioid use disorder, the data is pretty clear. It's medications for opioid use disorder. And those medications include buprenorphine and methadone. In a study done in 2020 out of Boston, one of the meccas, we saw a 90% reduction in death by adding medication for opioid use disorder and treatment. We know that we reduce overdoses by over 90% with molecules such as buprenorphine. And we know that we can reduce hospitalizations even higher. If there was one thing that I could bring to you today, it is that we need access to treatment and access for all Canadians, rather than stigmatizing and believing that these individuals don't deserve it. Because like all of us, they deserve the best health care that we can possibly provide. I could go on for hours, but I will pause there to keep within my 5 minutes and pass it on.
Thank you very much, Dr. Tanguay. Monsieur Letellier de Saint-Just, vous avez la parole pour 5 minutes.
Yeah. Thank you very much, Chair. Thank you, ladies and gentlemen, members of the committee. Thank you for this invitation on this subject, which deserves and merits all our attention. I'm here as the president of the Association of Quebec, the Addiction Workers Association. We work on prevention, obviously, and harm reduction, as well as reinsertion into society. This abuse of these drugs has been of considerable concern for the last few years. I've been militating and advocating for this. I'm founder of Cactus Montreal, which is the first syringe exchange program in North America, and I'm at the Institute of Sherbrooke in medicine, policy, and intervention in the field, in addiction circles. My position is very partisan, if you will. I'd like to see an improvement in drug policy based on a public health basis. The right to dignity of individuals who are dealing with this issue and access to medical services. I'm in favor of the recognition of scientific fact, and this allows us to undertake logical, coherent discussions and be critical as to the decisions that are taken. Measures have been taken since 2015-16. Well, first comment, the crisis existed far before that. The framework used to treat drugs is very politicized. We've used probable tools of repression and criminalization. Between 2005 2015, this has paved the way for the crisis that we deal with today. Nothing is perfect, of course, we understand. But this is decades of discrimination, a refusal to recognize scientific fact without any effort, and without giving us ourselves a time to reflect and build a proper policy. In our association, we have a complete recognition, appreciation of all the measures taken, and I'll name a few. A review of the Canadian strategy on drugs, We reintegrated the harm prevention or harm minimization measures which were removed in 2014. We revised the 4 pillars of the policy to make them more adequate and appropriate for the current situation. So it had to be done, and congratulations for doing so. The Good Samaritan Law was enacted to avoid any criminal liability for any individual assisting another individual who is in distress. There might be a small hic here. One wonders if all the politicians in Canada understand and appreciate the implementation of that act. Supervised sites, in-sites and such are on-site. We have over 40 of them today, and as mentioned earlier, and as you very well know, these are services that are used and useful. I invite you all to visit an in-site site elsewhere in the country. There's one here in Ottawa, I'm sure, and you'll see how they work. Decriminalization, or decriminalization, if you will, is an excellent measure. But with decriminalization in BC since 2023, we wonder what the situation is in Canada. We're a bit bipolar in Canada. It's a very uneven treatment. Let's try at least to make a success out of the BC project and the decriminalization elsewhere in the country. And now, perhaps a method for the future, a way forward, allow rapid access to addictive or addiction drugs. And don't fall victim to the criticisms that you hear, particularly quite recently when reaction to decriminalization in BC, because it's only been in effect for a year. These projects are essential. They're necessary. What we have to watch out for is the involvement of organized crime groups as to street drugs. That perhaps deserves much more reflection before you step forward to legalization. Thank you very much.
I have the floor for 5 minutes, please.
Thank you and good afternoon. So I'm Dr. Andrea Sarita, and I'm a physician working at the London Intercommunity Health Centre. I have 14 years of frontline experience providing primary health care to about 2,000 people living in homelessness and people who use drugs. As an emergency room doctor, I've resuscitated patients who have died due to overdose, and I've treated debilitating infections related to the toxic drug supply. I'm also the lead physician for Canada's longest-running Safe Supply program, which has been in operation in London since 2016. So there's many different models of safe supply, but today I'm going to speak about medicalized prescribed safe supply. And the goal for prescribed safe supply is to convert people who are using an unregulated, illegal street-based supply of fentanyl to a regulated, legal, prescribed alternative opioid of known dose and known purity. This goal is really important to understand in our discussions because the reason unregulated fentanyl is so deadly is not just because the fentanyl molecule is so potent. We use highly potent pharmaceutical fentanyl safely in emergency rooms, ICUs, ORs across the country every single day. But illicit fentanyl is so deadly because its composition and potency is so unpredictable. People who use drugs, they don't know if the piece of fentanyl they have is 5% fentanyl or 70% fentanyl. And it's this unpredictable variability in illicit fentanyl that is causing the devastating overdose crisis we see in Canada. And I explain the problem of fentanyl variability to my patients by using a metaphor that compares fentanyl batches to a batch of chocolate chip cookie dough. If you don't mix the cookie dough well enough, you can end up with a cookie that has 2 chocolate chips or a cookie that has 20 chocolate chips. These metaphorical cookies are from the same batch, but they have wildly different chocolate potencies when you bite into them. And the problem with illicit fentanyl is not knowing whether you have 2 fentanyl chocolate chips or 20 fentanyl chocolate chips. And by providing people with a prescribed safer supply of an opioid of known dose and known purity, they always get the same standard safe supply cookie of 10 chocolate chips. And so people know exactly what dose of opioids they are getting, and therefore they can be much safer when using them. Safe supply doctors like myself see safe supply as one part of a spectrum of solutions to the fentanyl crisis. Safe supply clinicians support our patients along the entire continuum of treatment, from abstinence to the prescription of medications like buprenorphine and Sublocade to residential treatment if that is the person's goal. Within prescribed safe supply programs, we provide the full spectrum of treatment for people with opioid use disorder. And safe supply is not a wild west of overprescribing, as some have described it.
Le programme d'approvisionnement sécuritaire est offert de façon sécuritaire à des gens qui ont des besoins médicaux forts, complexes, qu'on ne voit pas dans les modèles de traitement de la toxicomanie. Pour être éligible,
I just have to stop you there. I think there's a problem with the translation. Are you good?
technical problems been solved. Thank you.
Okay, I'll just give you. How does that sound now? Can you hear me, Michel Thériault? Okay. En français, ça marche pour mes collègues en anglais?
English, testing English. Can you hear the interpreter?
Go ahead again, please.
So as I was saying, safe supply is not a wild west of overprescribing, as some have described it in the media, but we prescribe safer supply very carefully to a group of people with highly complex medical and social needs that have not been met in other addiction treatment models. To be eligible for prescribed safe supply in the first place, people need to have experienced very severe health conditions due to their drug use, like untreated HIV or AIDS, frequent overdoses, or histories of severe infections. And safe supply patients, they've tried multiple previous treatment options before, like methadone, AA, residential treatment, often dozens of times, and it simply has not worked for them. And so prescribed safe supply is another tool in the toolbox for these people, and it has helped to stabilize a group of people with enormous healthcare needs. Despite the efforts of safe supply critics to say we have no evidence, there's a strong and growing scientific research base of high-quality research on safe supply. Our team has published a comprehensive program evaluation that found safe supply patients experience significant decreases in their number of overdoses and their use of fentanyl. This rapid decrease in overdoses experienced by Ontario safe supply patients is not unique. A recent study published in the British Medical Journal found that people in BC who were prescribed just 1 day of safe supply medications had a 61% decreased chance of dying the following week. And if people received 4 days of safe supply medications, they had a 91% decreased chance of dying. Our team published in the Canadian Medical Association Journal in 2022, where we used Ontario Health Admin data to compare people's emergency departments, hospital admissions, and amount of infections in the year before they were on safe supply with the year after they were on safe supply. And this data showed a 50% decrease in emerge visits and hospitalizations among safer supply patients, translating to a 50% reduction in healthcare costs among people prescribed safe supply. So to this committee, my job is to keep my patients safe, and the evidence shows that safer supply is helping to do that. I'll end my remarks here, and I look forward to answering your questions.
Thank you very much, Dr. Serretta. Ms. Hudspeth, you have the floor for 5 minutes, please.
Wonderful. Thank you for inviting me to speak to you today. My name is Maria Hudspeth. I'm the Executive Director of PAIN BC, a collaborative charitable organization whose vision is a future where no one is alone with pain. I'm joining you today from the traditional, ancestral, and unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. In addition to my role with PAIN BC, I was the co-chair of the Canadian PAIN Task Force, convened by former Health Minister Jeanette Petitpas-Taylor following the 2018 Opioid Summit. I was invited here to speak with you today about the role of chronic pain in the overdose crisis. What do we know about chronic pain? Very briefly, chronic pain is defined as pain that persists beyond 3 months. It can be caused by other diseases, injury, or surgery, and it can exist without an identified cause. It is prevalent, costly, and an often invisible condition. 1 in 5 people in Canada live with it across the lifespan. People who experience marginalization are disproportionately impacted by chronic pain, including Indigenous peoples, people who are incarcerated, veterans, people who are unhoused, and others. Best practice treatment includes what we call the 3 Ps, so pharmacological treatment, psychological support, and physical approaches. Well, what are the impacts of chronic pain? We know that in 2019, it cost Canada between $38.3 and $40.4 billion in direct and indirect costs. We know that people who live with pain are 4 times as likely to experience depression and anxiety and twice as likely to die by suicide. We know that untreated pain is a significant driver of substance use and the overdose crisis. Estimates vary, but consistently note that between 45 and 65% of people with substance use disorder report living with chronic pain. Chronic pain impacts our ability to work and earn a living, to go to school, to be a caregiver, and participate in our communities. Despite the prevalence, the impacts, and the tremendous financial and human toll, Canada has been slow to address pain as a priority across the health system, and approaches to pain have not been integrated into the overdose crisis response. What is the connection between pain and the overdose crisis? Well, we know that untreated pain is a significant driver of this problem. People who use substances and their families point to the lack of pain care as a contributor to substance use and also an impediment to successful treatment and recovery. One example, a study focused on primary care patients who used illicit substances. This study found that 87% experienced chronic pain and 51% reported using illicit drugs for pain relief. In BC, coroner's data shows that nearly half of all people who died of overdose sought care for pain in the year prior to their deaths. Starting in 2016, we began to see a pendulum swing away from prescribing opioids for chronic pain. The change was rapid, driven by new evidence, public discourse, and various regulatory and policy levers. Unfortunately, these changes have had significant unintended consequences, as access to opioids for pain was reduced without offering accessible, affordable alternatives. Many Canadians who had used opioids to manage pain have been weaned or cut off their medications. We know through both research and the stories of people with lived experience that this has driven some people towards the toxic drug supply with devastating and sometimes deadly results. While governments have noted these unintended consequences and revised prescribing guidelines, we have not seen a shift in practice nor a reduction in overdoses. Some people who live with pain have called out the irony of safe supply, with deprescribing of opioids for pain on one hand and prescribing of opioids for addiction on the other. As an organization, we care about all people who live with pain. So this distinction between legitimate pain patients, as sometimes has been noted, meaning people who don't live with addictions, and people who live with concurrent pain and addictions, to us, everyone who lives with pain deserves care. The overdose crisis has continued unabated despite tremendous investment in prevention, harm reduction, and treatment. What has lacked investment is pain management as an essential component of our health system and our overdose response. The Canadian Pain Task Force was mandated to assess the state of chronic pain in Canada, to advise on best practices and make specific policy recommendations in the form of a national action plan. This action plan was released by Health Canada in April of 2021, and implementation is ongoing through top-down and bottom-up approaches.
Ms. Hudspeth, I'm going to have to stop you there. Your 5 minutes are up.
Okay, thank you.
Thank you. Just so we're all very aware, we have a convention in this committee so that if someone is asking a question, what we suggest is that the response is the same length as the question, and the member will have the opportunity to interrupt you should they desire at that same length. So we will stick to that convention as per the usual chair. So with that being said, let's get to the first round of questions. We'll begin with Ms. Goodridge. You have the floor for 6 minutes.
Thank you, Mr. Chair. It's wonderful to see you in that spot. Thank you to all the witnesses for making time to be here today as we study this really important topic. I'm going to start out. My first question is for you, Dr. Sereda. New information has recently been released that corroborates previous reporting that there's mass safe supply diversion happening near the Chapman's Pharmacy close to your clinic. Are you aware of this diversion near Chapman's Pharmacy?
A question for you as well, Ms. Goodridge. What evidence has been released showing this?
It was in a series of tweets from one of the journalists, Adam Zivo, and it was put out already today.
Okay. So, I mean, safe supply clinicians, we rely on good research and published evidence and not on anecdotes and tweets on the platform of social media, Twitter X.
Okay,
and
thank
so,
you. So are you
Excuse
aware?
me, Ms. Goodridge. If she had more, we'll give her another 20 seconds, please.
And so Mr. Zivo is a columnist for the National Post who has dipped his toes into this for the past 8 or 9 months. And he certainly, you know, early in his writing about safe supply expressed his desire to burn the whole system down. So I'm not sure that he's a terribly credible source of information that we want to rely on in this committee. In addition, Mr. Zivo has visited Intercommunity Health Center, where he was actually a very bullying presence to my patients. There is a gate just outside my clinic door that is 3 feet from my clinic door. I'm not finished, Ms. Goodridge.
It doesn't really matter whether you're
Mr.
finished or
Zivo
not.
blocked access to health care through
I'm
the
sorry,
only
Dr.
door to my
Sereda, I
clinic.
think I made you aware very clear of the convention we have in this committee. I really request that you respect that. I've done that with respect to Ms. Goodridge. So again, let's be respectful today, everyone. Thank you.
Does diversion of safe supply worry you?
I think more important than diversion is the discourse around the diversion that's happening in the media. And so
Okay, thank you.
diversion is complicated, and it requires more than a 60-second
Thank
answer
you.
if I can finish.
I appreciate that. I have a very limited amount of time, so I asked really quick, simple questions and wanted simple, quick answers. BC's recently developed some protocols that allow for recreational fentanyl to be prescribed to children in the guise of safe supply. What are your thoughts on this?
I think the BCCSU has very carefully consulted experts, both in who provides addiction care, harm reduction care, and the care of children with substance use disorders. And so I'm not aware that any children have accessed this protocol to date. But if you read the protocol, it is the same as any other kind of complicated health care for children in Canada, whereas 2 experts need to agree. The person needs to be carefully assessed for their risk and any benefit of treatment. And in some children who are dependent on the toxic, illicit fentanyl street supply, physicians who are caring for them can make expert decisions in what they need for their health care.
So do you think that we should prescribe recreational fentanyl to children?
I think if children are at risk of dying from the toxic street supply, which we know over 90% of deaths in youth are from, which is illicit
Thank
fentanyl.
you. I'm going to turn that over to Dr. Rob Tanguay. I'm wondering if you could perhaps expand on this. What are your thoughts when it comes to prescribed recreational fentanyl to children, as been suggested by British Columbia?
Well, I'm in a belief of focusing on treatment and a process of such. I think at the end of the day, the prescription of recreational substances to anyone without a diagnosis and a treatment algorithm can be problematic. And there's really no research or evidence or peer-reviewed literature to suggest otherwise. That being said, if it's a molecule and it stabilizes someone and it's in a guise of helping someone recover from a severe addiction, then I'm all for whatever that molecule may be. It comes down to whether we're focused on treatment and what that algorithm may look like.
Thank you. One of the big questions that we've been facing as we've been looking at this is the idea between what does treatment look like, and I'm just wondering if you could describe some of how you approach addiction medicine and treatment, and how that can look in your practice.
Yeah, for sure. So I work in the Rapid Access Addiction Medicine program that I co-founded. It's Alberta's largest addiction medicine program. And everything is about meeting people where they are. And then with the utilization of motivational interviewing, which is really in common sense terms about being nice to someone, listening to someone, and helping them where they want to go and what they want to do when it comes to recovering from addiction, from mental health, from homelessness, from the sex trade, from whatever they're trying to get out of, which often these are all intertwined together. And so treatment is really about a pathway.
So you're talking about this rapid access program. I don't know if everyone's necessarily familiar. Could you explain a little bit how people would access a program such as that and how something like that actually works?
And Dr. Tange, you have about 20 seconds since we had to interrupt the questioning. Thank you.
So they can walk in, they can self-refer. We get referrals from emergency departments, from inpatient groups, from primary care physicians, from counselors, from psychologists. It's wide open. We have full and complete, absolute rapid access to anyone and everyone in Calgary.
Thank you very much. Madame Brière, vous avez la parole pour 6 minutes.
Thank you, Mr. Chair. Merci à tous les témoins.
Thank you, Chair, and thank you to all the witnesses. Mr. Letellier Saint-Just, thank you for participating in our meeting today. We have a link, of course, Sherbrooke University. I studied there. In your preliminary comments, you said from 2005, 2015, the previous government have taken the road of repression and criminalization in their fight on drugs. Since the measures taken since 2015 to base it on scientific evidence is a more modern, contemporary approach, I believe, and I'd like to give you the opportunity to give us some more details as to whether or not we're on the right path here. The purpose, so everyone agrees we're here to try to save lives, so let's hear from you. Yes, of course, we're on the right track right now. The concern that we have is that some people want to turn back the clock, and that would be a major error. Where would we be if this repressive policy would have been continued after 2015? The crisis would be completely out of control. Now, let's not confuse decriminalization as a path to the solution of access to illegal drugs. That's not the objective. The objective behind decriminalization is to provide access to services. Dr. Tanguay and Sereda both mentioned it. We're there to offer access to service. Everything dealing with the application of the law, money laundering, smuggling, illicit crime, did not increase because of decriminalization or even delisting of some of these drugs. This has not changed the character of the black market in drugs whatsoever. We'll have to go further if we are to resolve that. And this is why we have to. Legalization scares people. But we've done it for cannabis. And we have stats now for the last 5 years, and it's very positive. Why not go further with selective drugs, or perhaps all drugs eventually? In Amsterdam, the mayor of Amsterdam called on all the major cities of the world to say, what are your objectives vis-a-vis the takeover by criminal groups in your major cities? We're in the same situation in Canada. It may not be as evident or as visible, but we are, in fact, being affected by criminalized, organized groups. We have to continue to be consistent with the measures we put in since 2015. Well, do you think that these 4 pillars, prevention, respect for the law, the way it's being handled. Yes, the 4 pillars of the Canadian Strategy on Drugs. Fortunately, it's been tweaked lately, and this is the model which will serve. Thank you very much. Dr. Sereda, in your opening comments, you also mentioned that you were there to ensure the safety of supply, the safety of your patients. I'd like to hear more how safe supply has had an impact on your clients and patients.
Question, and thank you for giving me an opportunity there. My patients are the focus of my work, and I'd like to tell a couple of stories if I have time in the moment. I'm going to start with a story about a woman who was diagnosed with palliative AIDS, and she lived on the street. She had no health care. She came into the hospital. Actually, she repeatedly came to the hospital with pain and was turned away over and over and over again because she was labeled a drug seeker. And eventually it was discovered that her pain was actually due to the consequences of HIV and the infections she had related to AIDS, and so she was admitted. And at that time, she was told she was palliative, that nothing could be done to help her. And she was discharged to the street, back to homelessness with a palliative AIDS diagnosis and no medications and no support. So it was at this point that our team had a chance to intervene, and we brought her into care, and we prescribed her safe supply, and her fentanyl use completely stopped. And she is now housed. Her AIDS is no longer AIDS. It is well-treated HIV with a controlled viral load. Like I said, she is housed. She is now volunteering in harm reduction programming. And really what she needed was that support to move away from the toxic supply so that she could focus on health issues as well. And she makes really great cupcakes. Do I have time to tell you another story? Okay. Another woman I want to tell you about was also palliative. And this woman, she was deemed to be palliative because of endocarditis, which is a severe heart infection. And so she was in the hospital and she needed surgery and she needed to receive 2 new heart valves in order to survive. And at that time, the surgery team did not feel she was a candidate because she was a drug addict and she had done this to herself and she was going to do it again. And so, again, at this point, our team intervened and there were some
Dr.
strong
Sereda,
advocacy
I'm going to have to interrupt you
discussions.
there. The time is up, but maybe someone on your team will come back to that. Thank you. Monsieur Thériault, vous avez la parole pour 6 minutes.
Mr. Thériault, 6 minutes.
So thank you very much for that opportunity. So again, we intervened with this woman, we advocated, and we put her on safe supply as well, which again extinguished her fentanyl use. She was able to receive her 2 new valves. She was only 21 years old when she told she was going to die from endocarditis. That was more than 4 years ago. She's 25 years old. She no longer uses fentanyl. She is still on prescribed safer supply. She is housed. She also volunteers with us, and she's returned to college, and she really enjoys singing and dancing and knitting in our clinic.
Merci.
Yes, thank you for that. Well, before we've had this crisis and overdoses, we were looking at safe supply in injection sites, InSite model. Now, the problem with safe supply is the fact that there are still access to street drugs and the diversion of the safe supply. So perhaps you could talk to us about that issue to see what you've seen and any changes in the last year or two. We have to overcome this diversion of proper drugs. Perhaps Dr. Freda, who didn't have a chance to complete her comments, and then you can hop in.
So it's also important to remember that Safe Supply is politicized just the way safe consumption sites that you mentioned have been politicized. You know, needle exchanges were illegal during the time of HIV, and so Safe Supply is undergoing that same kind of moral panic and disinformation. And when you speak to what is needed and the concerns around diversion, I'm going to tell you another story. And this is going to be a hard one for me to tell. But I was approached by a father at a community event last year.
J'aimerais vraiment vous parliez du détournement.
I'd really like you to focus on diversion. We have very little time, but perhaps you can tell me what you think of it, what is the actual experience in the field, and how we can overcome it if possible.
Absolutely, and the story I'm going to tell speaks directly to diversion. So I was approached by a father in the community, and he told me he had lost his son to a fentanyl overdose in the year prior. And he told me that his son died while he was on my waiting list to access Safe Supply. So he died waiting to see me so that I could maybe save his life. And I expected this father to be angry with me. I hadn't been able to see his son, but he wasn't angry. And what he told me next surprised me even more, and this is about diversion. He told me that his son had stayed alive longer than he had expected because he was able to get Safe Supply hydromorphone tablets from a friend he was staying with and who was willing to share with him because his friend couldn't watch him go through the profound withdrawals of fentanyl. He wanted to help him. And his friend stopped eventually giving him these hydromorphone tablets, and the son went back to using fentanyl. He died very soon after. As a prescriber, I don't support diversion in any way at all. I expect my patients to take the medication as I prescribe them. But the discourse around diversion, it forgets that diversion is a signal of unmet need in the community. We have just, barely 6,000 folks on Safe Supply across the entire country, whereas we have tens of thousands, if not 100,000 people who use drugs. And we know from the methadone literature that most of the time that people are doing what we call diversion is actually helping the people in their community survive to see the next day.
Mais des gens prétendent qu'on va.
But people contend that these drugs are prescribed to children. Is this so? And what can we do to see that this diversion doesn't affect that part of the users?
Complété tout à l'heure, mais est-ce qu'on doit être surpris?
Should we be surprised that there is diversion, in fact, of prescriptions? No, it's not a surprise. I mean, you shouldn't be shocked by it. It's unfortunate. It's not correct. But it's up to the doctor to remind his patients the danger that they are risking if they share their pills. Now, we don't have statistics on that specifically. But if you think of Marianne Gollier in Quebec, or Ms. Morin, another doctor, very involved in the community, and they're aware of this reality. They do their work exceptionally well. They're part and parcel. It's part and parcel the responsibilities of the College of Physicians of each and every province to ensure rigid respect for that. They have to take a position. They have a guide as to the prescription of these opioid drugs. It's a responsibility which is inherent in the position of the physician. They have to be more vigilant, and they have to be very careful of who's prescribing what to whom. Would you like to add anything?
Désolé, Mr. Thériault, mais
I'm sorry, but I'm afraid that's the end of the round for now.
the floor for 6 minutes, please.
Just in the spirit of goodwill, I'm going to allow Dr. Sereda to also comment on Mr. Thériault's question as well.
Okay, thank you for that opportunity as well. And I was listening carefully in my headpiece, so please stop me if I've misinterpreted the question. But you're speaking about youth and concern that, Safe Supply is being diverted to youth. And I think it's really tragic that Canadian youth are actually also being used in this polarizing rhetoric about the potential impacts of safe supply, because I do believe that they're being used. Coroners in BC and Ontario carefully monitor overdose deaths. There's absolutely no data to support that children are accessing hydromorphone and dying from them. In fact, we see children overwhelmingly dying of the toxic illicit fentanyl supply when they do have an overdose. And so obviously, you know, I'm the parent to a small child. Would I ever want her to be able to access opioids? No, I wouldn't. And all safe supply clinicians are like that, and we take all of the precautions that are available to us to make sure that our own patients are taking the medication. Is it perfect? It's not perfect, and maybe you'll give me a chance to speak to our diversion protocols, which are very robust. But again, this dialogue that you see in the media and by critics of safe supply about the children, I think it's quite sickening that Canadian children are used in this way, because the data does not support these assertions whatsoever.
Dr. Sereda, you know, in terms of, you talked about anecdotal tweets driving, you know, the agenda and political discourse. Can you speak about the impact of that on, you know, in terms of the crisis, the impact of that on frontline staff and patients, people that you're working with?
I mean, yes. When politicians spread disinformation, people die. And people die because of many reasons. It's delaying the emergency response that we so badly need in this crisis. We can't forget that over 42,000 people have died from overdoses, and disinformation that actually slows our response to saving, you know, the next 42,000 lives is really, it's disappointing. I would like to see people who spread this disinformation, politicians, media, critics, I would like to see them be the ones who call the mothers of the dead. Because I think if that was their responsibility and not my responsibility, that they would really be focusing on the emergent nature here, on the actual evidence that we have around safe supply and other harm reduction interventions. I think it would be a lot harder to play politics with people's lives.
You talked about the cause of delays, and obviously, you know, we've got the government taking an incremental approach. I would imagine that this, you know, discourse is having a huge impact on it, on slowing the response. Can you speak about the impacts of, say, the delays in the SUAP funding right now, getting out to those organizations and clinics like yours that are, you know, have patients and teams that are required to deliver medicine to people, life-saving medicine?
We are all waiting on the edges of our seat to know if SUAP funding is going to be renewed or extended. And we're scared, and our patients are scared alongside us. You know, my patients are marginalized in a way that suggests that they're not part of the over community, but they are, and they read the news. And my patients are scared. They've been asking me most days for the past 6 months if they're going to lose their scripts, if they're going to have to return to what their lives were previous, if they're going to lose connections with their family, if they'll lose housing, if these programs end and they have to return to the toxic supply. They ask me if they're going to die. And I don't have an answer for them because I don't know if funding is going to be renewed. And the clinicians, for us providing this care, it is an absolute moral distress. We know that when people are deprescribed opioids, as one of our speakers mentioned today, that they turn to the illicit market. And we have decades of data around the opioid crisis since the early 2000s showing that deprescribing predictably leads to death. And so clinicians are in this position where most clinics, most safe supply clinics have maybe a month left of funding, and we don't know if it will continue. And clinicians are stuck. Do they wean people knowing that data shows that many could potentially die if they do so? Do they transition them to more conventional addiction treatments like OAT, such as methadone and buprenorphine, knowing that these patients, have failed multiple times on these previous medications, and the fact that they've failed has led them to be part of a safe supply program in the first place. Clinicians don't know what to do. The moral distress comes from knowing they've been keeping people alive for 3 and 4 years on these programs and not knowing if in a month the people that they care and serve and love are going to die.
Mr. St. Jude, did you want to add to that?
Well, if I understood well the question, c'est aussi la même chose pour nous lorsqu'on a.
Well, the same thing, same situation when we hear critical and negative criticisms. Look, one can be concerned, be cynical or skeptical and be critical. That's fine, whether it's for supervised site, whether it's safe supply. But this is being done in a context. I'm sorry, but we're at the end of our round of questioning. I'm sorry, I have to interrupt you there.
Everyone's clear. The next round of questions from the Conservative side and the Liberal side will be 5 minutes. However, the Bloc and the NDP only have 2.5 minutes, so be judicious with your responses. Thank you very much. Mr. Doherty, you have the floor for 5 minutes.
Thank you. Dr. Sarita, I don't believe you answered the question from my colleague earlier. Are you aware that there is safe supply being diverted at Chapman's Pharmacy across the way from your office? Yes or no?
It's not a yes and no answer.
It is a yes or no. Are you aware or no?
I'm going to decline to answer a complicated question.
Okay, that's fine.
Without being given a chance for a complicated answer.
Okay. That's fine. So you deny that it's happening across the way?
No, that's not what I said, sir. I said I needed time to explain.
Okay. Do you agree that it's possible that diverted opioids are ending up in the hands of people that they aren't prescribed to, or even children? Yes or no?
We have no evidence that they are ending up in the hands of children. We have no scientific data that supports those assertions.
What's the leading cause of death in the province of British Columbia for youth?
It is overdose from fentanyl.
Thank you.
From fentanyl.
Okay, thank you. What is your relationship between the clinic and Chapman's Pharmacy? Is there one? Do you meet with them regularly?
We have a professional relationship because due to their proximity to our clinic, a majority of our patients choose to use that pharmacy. And so we are in nearly constant communication about how to better serve our patients and improve health outcomes.
Do you believe that physicians that prescribe safe supply are morally or legally responsible for diverted safe supply prescription that bear their name?
I believe that every medication that has any kind of value can be diverted. And of course,
Are you morally or legally responsible as a physician for that medication if it is then taken as you prescribe it and then sold on the street?
I am morally responsible for my patients to stay alive. I am morally responsible to care for my community.
All right.
And the suggestion that safe supply clinicians don't care about the larger community is quite frankly extremely
I didn't say that,
offensive.
actually. I just asked you if you felt that morally or legally that physicians that prescribe safe supply, are they morally or legally?
Responsibility to our clinic.
Thank you.
The legal responsibility,
appreciate that.
you'll have
Thank
to
you.
ask the lawyers.
A healthcare worker purchased thousands of hydromorphone pills prescribed through your clinic, which led him to escalate his addiction and cause serious harm to himself and his family. What would you say to him, his wife, and his children?
I'd like to know where this anecdote is coming from first.
Well, I never asked you where your anecdotes came from, so I think it's me, again, asking questions. That's my time. Dr. Sarita, how often have community members, including family members of your patients, tried to contact you to express concerns about safe supply diversion originating from your clinic?
Community and family members? Never. We encourage family members to come into our clinic with
So
their
at no
family.
time has a patient's family member come to you? Okay.
No.
Okay. Do you support the improved traceability measures of so-called safe supply?
I don't. I think that's a slippery slope around marginalized
Why would that be a
communities.
slippery slope?
We don't put tracers in any other kind of medication.
So can
Why
diversion-
would we stigmatize people who use drugs? Why would we assume that people who use drugs have nefarious intention with their medications?
Wouldn't you
we
want to
know
make
that
sure?
over 90%.
Can you and I agree that there are many different tools around this table, and there's many different views, but do you not think that we should be doing everything in our power to make sure that we're keeping people safe?
Yes, I do, by
Okay, so
investing in evidence-based programs.
Do you believe that traceability would then cause diversion to maybe come down?
No, I don't. I think it would cause people not to use harm reduction programming because this is a group of people who have been criminalized for decades, actually 100 of years. These are people who, you know, on our program, we have 30% Indigenous folks, and we know that is true of most safe supply programs. I don't think anybody who has had a violent relationship with the structures of medicine and government is going to be wanted to be tracked in any way, so it will
Dr.
lead to
Sarita,
death
is
because people will
diversion
not seek
illegal?
treatment. Is diversion illegal?
Yeah. Yes
for
or no?
people to sell their medications, yes, that's illegal, just like they sell methadone.
Okay. Did you receive $1.5 million from the National Safe Supply Community Practice that deems what's their words? They deem diversion as compassionate health care?
So I did not receive that money. Certainly the
did your
Safer
clinic?
Supply Community of Practice received that money. I'm aware of the diversion document that you're referring to, and it was written by expert clinicians as well as evidence and advice.
How can
from
you
people who
justify
use
that
drugs.
funding though? If it's an illegal practice?
So I think you're referring to the funding for the community of practice, the National Safer Supply Community of Practice. It's not funded to defend diversion. It's funded to support people nationally in learning about safe supply.
Thank you, Dr.
helping them in
Sarita. I'm going to have to
practice
stop you
and
there as well.
disseminating
Thank
information.
you very much. We're going to move on to Dr. Henley. Dr. Henley, you have the floor for 5 minutes.
Thank you. I want to thank each of you for being here, and each of you for your dedication to practice and to this particular crisis. Dr. Sarita, I'll let you carry on for a moment, but I do have questions for at least 3 of you. You so eloquently documented the benefits of safe supply. I do want this study to be so much more than this false argument on safe supply and its role in healthcare. Should politicians be making treatment recommendations?
Just before you start that thought, Dr. Sarita, the interpreters are asking Dr. Hanley if you could raise your microphone to just between your upper lip and your nose, please. I'm sorry, Dr. Sarita.
Thank you, Mr. Chair. Is this better? I'll let Dr. Sarita continue and then.
So I'm not aware of any other health condition in this country where politicians actually weigh in on whether it should be provided or not. Politicians in diabetes care, surgical care, hypertension care, they defer to the expert clinicians, expert researchers in these fields because they know that they are experts and they know that they want the best for their patients and they know that they're going to offer them treatments that are going to be beneficial. It's only in this extremely politicized, rhetorical debate around harm reduction, where politicians seem to think that they know better than the experts, better than the people who are caring for these patients day in and day out, and who have a fiduciary responsibility to see that these people stay alive and do well, both in health and social outcomes. And so, again, I've used the word. Thank you.
I appreciate this, but I do have to move on. Dr. Tanga, your first words were very moving, and I'm really sorry for your personal losses. And I think it speaks to many of us who have also experienced losses in our families or our communities around the country. I was also very heartened as well by your answer to the question on prescribed fentanyl. First, you cautioned against such treatment without a treatment plan or diagnosis, something I think anyone involved in treating opioid use disorder would agree with. And you also said that you support the use of any molecule that helps to stabilize an individual within a treatment plan, if I can paraphrase you anyway. And I think that speaks to and validates the 4-pillared approach that includes treatment and recovery. You've spoken a lot about the various pillars of treatment, including you cite the important role of harm reduction, but you have argued that harm reduction needs to include mental health services and addiction services and be better connected to community and residential treatment programs. So in your opinion, under what conditions should supervised consumption, safe supply, and other harm reduction measures occur in Alberta and in Canada for that matter?
Thank you, Dr. Hanley. I think that at the end of the day, trying to create a system that makes sense, that's interconnected and not siloed, We have harm reduction silos, recovery-based silos, mental health silos, and the reality is there's a lack of access to any of them. And that's really the biggest problem that we have. We're sitting here talking about a new treatment algorithm that really was an experiment and is building evidence for sure, without actually accessing first-line treatment. And most people in Canada do not have access to first-line treatment, do not have access to mental health treatment, do not have access to supports. You know, these supervised consumption services should be an entry point to treatment. And probably one of the best entry points to treatment for individuals who are most vulnerable that we could possibly have. But you know, the concept of meeting them there is so important, but we can't just leave them there, and we can't help them.
If you don't mind, I'm going to cut you off. Thanks. I just want a few seconds with Ms. Hudspeth. Ms. Hudspeth, thank you very much for appearing. And in my previous role, I had the pleasure of leveraging your organization's expertise as we began to look at critical gaps in pain care in the Yukon Territory. What do we need to do better as a public healthcare system in managing pain? And can you also talk briefly about how we support self-management of pain? Because I know you have been leaders in that area.
Thank you so much. We've been making great strides on the self-management side and building out virtual care, but also supports to enable people to use those things. So people can throw up a website and it can have all kinds of great resources, but people often need a hand to hold as they walk through that and as they apply those learnings. What we need to do is we
Ms.
need to
Hudspeth,
be...
I'm sorry, I'm going to have to interrupt you. The time is up. I apologize. So, moving on, Michel Thériault, vous avez la parole pour 2 minutes et demie.
J'essaie d'être bref.
2.5 minutes, Mr. Thériault. I'll try to be brief. Mr. Tellier de Saint-Just, in a very interesting document, 9th of February 2024, you indicated that decriminalization does not ensure safe supply. But you also target and are quite critical of organized crime involvement. Now, the 4 pillars, you agree with that. Do you think that we're doing enough to combat the criminal element in all of this? Because when it's a matter of money, the criminal sector doesn't care of the consequences. It's a black market. Are we doing enough? And if not, what more could be done? As quickly as I can, in Amsterdam, a policeman working in the criminal field identified organized groups. He says, you know, we prepare for months to do a raid, seize enormous quantities of drugs. The number of hours that it lasts, this raid, this removal of those drugs, 2 hours. 2 hours. It's terrible because this is not a fair fight. The way we deal with the organized, the forces that they have, the criminal element, are much greater than the force of law and order. We have to deal with money laundering. We have to watch the borders, whether it's Montreal, Amsterdam, Rotterdam, elsewhere. We have to control the entry of this. But we're not. It's not a fair fight. They're bringing a knife to a gunfight. So perhaps is to work our way towards the regulation of more drugs, let's say, cocaine, for example, or MDMA, ecstasy. This track, or at least think about it seriously. You've answered my question. Thank you. Thank you, Mr. Thériault. Mr. Johns.
1.5 minutes, please.
Thank you. My question is to Dr. Tanguay. And first, Dr. Tanguay, I also share my condolences to you and your family for your losses. I know, Dr. Tanguay, you're part of a report commissioned by the United Conservative Party in Alberta in 2020 on safe consumption sites in your home province. And that study has been widely criticized for its poor scientific methodology, and yet was key to the closure of the safe consumption site in Lethbridge, which has reported a record number of fatal overdoses since the closure of that site. Additionally, a study was published in the Lancet this month showing a 67% reduction in overdose deaths in neighborhoods within 500 meters of safe consumption sites after they opened. It demonstrates that life-saving impacts of these sites and the importance of them. Have your views changed since this government-commissioned report was used to leverage the closure of safe consumption sites in Alberta?
So just to be clear, the consumption site in Lethbridge was transitioned to an AHS-1 out of a not-for-profit. It's still active and still going, and never has it turned someone away. There's a record overdoses in all sites, whether one of these consumption sites exists or not, whether treatment is available or not. I don't think that picking a specific small piece and saying, here's the answer is always the easiest way. Supervised consumption services, and the report never said once to shut any service down. It was never once written in that report to shut any supervised consumption service down, but rather that these services require support such as medical treatments, buprenorphine, methadone, mental health treatments, wound care treatments, primary care treatments, that the big support is that these processes should be more than under the realm of harm reduction and rather under the realm of healthcare. And that was something
so you believe, Dr. Tanguay, that there should be more safe consumption sites, including maintaining and improving the one in Red Deer, for example?
I believe that safe consumption or supervised consumption services are a part of a pathway of treatment, and like all harm reduction services should be a part of the treatment algorithm. I think that the biggest problem that we have is that we pick one little piece.
I'm sorry,
and then
Doctor.
we focus on it and think that's all we need, and that's not an answer. Sorry.
Thank you, Dr. Tanguay. Mr. Johns, that's the end of your round. We will now turn to Mr. Doherty. You have the floor for 5 minutes.
Thank you, Chair. Dr. Sarita, in January 2022, you produced a report that claimed your program was successful because of a 94% retention rate, which is a surprising finding that people with addiction will return for free government-supplied drugs. It was only later during a webcast that when you were asked directly about the other 6% who were no longer enrolled that you acknowledged some of the 16 had died from fentanyl overdoses or from infections acquired from injection drug use. Your study also did not analyze the impacts of diversion. How can you claim that it shows hydromorphone from your program works?
So I think there's always this question of is it the safe supply that is that is making people well, and what we need to know is the outcomes that we are seeing. We compare them to match controls in people who are not receiving a safer supply, and we simply could not see the positive health and social outcomes that we were seeing if people were on mass diversion, as is being alluded to here in this committee. The 6% of folks that we lost were to long-term incarceration, long-term hospitalization, and yes, we have tragically lost some people to infections and overdose. What we do know is that people who are confirmed by urine toxicology to only be using their safe supply, only using safe supply hydromorphone, 0 of those people have died. It is people who continue to engage with the toxic illicit fentanyl street supply that have gone on to overdose. And we know proportionally we've lost so many less.
So it's interesting you say that because you're familiar with Dr. Sharon Koivu. So Dr. Sharon Koivu is a site chief at the London Hospital, former acting medical officer of health. A study by her and Alison McKinley, a nurse practitioner, I'm sure that you're aware of this, that examined the charts of over 200 patients who had been referred to Victoria's Hospital Addiction Medicine Consultation Service between January and June 2023 shows that safe supply hydromorphone from your program is causing harm such as serious infections and new addictions. What do you have to say about that?
I have lots to say about that. So I've actually been in communication with Dr. Koivu about this the data that you just discussed for about 3 months, maybe a bit more, trying to actually find out what her methodology, her inclusion and exclusion criteria.
You're questioning her methodology, is that?
Yeah, because she doesn't release it. This is not a published study. There's no
So that
evidence.
would be anecdotal information as well.
When I have approached her, she's told me she actually cannot discuss any of this with me. Although she can't discuss the findings of her research or just, give her methodology, which all good researchers do, she can release it to Adam Zivo of the National Post, and she can release it on social media. These things don't line up.
Dr.
And when you
Koivu
look at the
has also
denominators,
stated that some of her patients who get Safe Supply hydromorphone from your program have housing but choose to sleep outside Chapman's Pharmacy in tents to be first in line to get the prescription in the morning, which they often sell so they can buy illicit fentanyl. Some of these patients are vulnerable women who are being pressured to secure as much hydromorphone as possible so that their spouses or pimps can confiscate the drugs for resale. These patients also claim that the criminals wait outside their pharmacy and intimidate vulnerable people to hand over the hydromorphone. What do you have to say about that?
I would say that Dr. Koivu tells a lot of stories. Another story
So again,
she is...
you're discrediting another doctor. Is that what you're doing?
I am saying that what she has shared with you is not accurate in my experience. Dr. Koivu has also testified that Safe Supply has a 100% mortality at 5 years, yet she works in a community that has had Safe Supply for 8 years and has 300 living patients. So I think we need to take those reports with a big grain of salt.
So, Mr. Chair, how much time do I have? 1 minute. So Dr. Koivu has also stated that Safe Supply hydromorphone from your program was present in London before there was much, if any, illicit fentanyl, and that hydromorphone from your program has fueled fentanyl gangs and new addiction.
I really think
you discredit that as well?
I really think that speaks to Dr. Koivu's lack of experience with this population, because that's not true. Fentanyl was present in London, Ontario since 2012, and it really started to pick up in 2013 through 2015, which is why we actually started the program in 2016, because at that point, fentanyl was dominating the opioid sales on the streets of London, and that's why we needed to make a change at that point.
Dr. Samuel Weiss from the Canadian Institute of Health Research testified to this committee on December 4th that based on a study they were conducting on 11 Safe Supply programs, wraparound supports are critical to any purported benefits from the programs. Given that your program offers wraparound supports, how can you credibly claim that Safe Supply hydromorphone is providing any benefits?
So first, I think it's pretty funny that, a criticism of Safe Supply programs is that they give excellent care and excellent wraparound supports, but also the data that I presented to you from the CMAJ study, it was before we had SUAT funding for those wraparound supports. The data I reported to you about 50% reduction in emergency departments, admissions, and amount of infections, and 50% reduction in cost was only Safe Supply prescribing. At that time, we had no wraparound supports.
Dr.
That
Sarita, I'm
speaks
going to have
clearly.
to stop you there,
Thank
please.
you.
Time is up. Dr. Poloski, you have the floor for 5 minutes.
Dr. Sarita, convince me. I like Gord Johns over there. He's a very passionate guy. I think he's got a lot of good ideas. My daughter actually works in the homeless community in Vancouver and is a big advocate for Safe Supply. She's having trouble with Dad. And I'm not just a politician. I worked in acute care medicine almost 40 years, including 20 years in Thunder Bay Emergency Room, which sees its fair share of overdoses. We've heard anecdotes on both sides here, but I'd like you to comment on the recently released JAMA internal medicine study from January 2024, British Columbia's Safer Opioid Supply Policy and Opioid Outcomes, where they found that after BC instituted a safe supply, opioid-related poisoning hospitalization rates increased by 3.2 per 100,000, which was statistically significant with a p-value of 0.01. And although deaths from opioid toxicity didn't increase significantly, they did increase, and the p-value was 0.26. And in the authors of the paper, in their commenting as to why these numbers went up, they said, what could explain the higher hospitalization rate after the policy's implementation? One potential reason is the participants in British Columbia's safer opioid supply policy program diverted safer opioid supply for various reasons, including to purchase unregulated fentanyl. It is also possible that a higher supply of prescription opioids led to an increase in prescription opioid misuse, which in turn could increase hospitalization risks. So it doesn't look real positive for safe supply. Maybe I could just have your comments with respect to that.
So the authors of that JAMA article seem to confuse correlation with causation. We know that there are about 4,500 people on safe supply in British Columbia, but we also know there's over 225,000 people who are diagnosed with opioid use disorder and use street-level fentanyl. And so the idea that we can have a population effect from 5,000 people in the context of a denominator of 225,000 people is not reasonable. Safe supply prescriptions are not prevalent enough to be able to do that. We also need to remember that over 90% of hydromorphone prescribing in British Columbia is actually to chronic pain patients and not to safe supply patients. They're less than 10%. And so the reason, fatal overdoses have climbed in BC is actually because of an increase in the volatility in the supply. During that time period, we have seen the introduction of benzodiazepines, the introduction of xylazine to the toxic supply. People are dying because the fentanyl that they're using is more deadly.
Let me just point out, though, in that study, they also compared mortality rates in British Columbia versus Manitoba, what other provinces? Nova Scotia, I think, Saskatchewan, a number of other places which did not institute safe supply, but they looked at their rates over the same period because they said, well, is this because there's a more unsafe supply of fentanyl? But BC's increased more. So, and yes, you can't prove causality, but certainly it's suggestive that there's a problem there, and certainly the authors pointed that out. Could you please, send me the evidence? You say there's a lot of evidence for the use of safe supply and how it helps. I mean, this is all my evidence. I have it all before me, and I'm looking at it. And the one fairly good paper, I think, was the BMJ paper of 2023, Sloan White. Now, I could talk further about that because I would suggest that there are possible problems with that paper. The CMAJ paper of 2021, which was London, but as has already been pointed out, it wasn't just safe supply. There was also comprehensive health and social supports involved. I looked through all the other studies that were quote-unquote evidence. A lot of them were basically a bunch of anecdotes where they talked to people on safe supply who said, yeah, I feel better on safe supply, but not exactly good evidence. And a lot of the other trials, the Andalusian trial, all the heroin-assisted treatment studies, those were all with directly observed treatments, not letting people go home with a lot of narcotics. So if you could please send me the evidence. And then lastly, if I still have time, I'd like you to comment that we had the chair of the Lancet Stanford Committee who was against safe supply, and his reasoning for being against safe supply was he said, well, why do we get into this trouble to begin with? It was because the overprescription of narcotics by us doctors, which then ended up, and there's evidence that it's often not the person who's prescribed it, but someone else either using their drug, someone else in the family, or it being sold to other people, that was the source. And how can you argue against his saying, well, if we provide safe supply, we're just doing the same thing again?
Well, Dr. Pawlowski, I'm enjoying your scientific debate with yourself. However, unfortunately, there's no more time. Perhaps your colleague, Ms. Sidhu, may have that question answered for you. I do apologize for that. Ms. Goodridge, you have the floor for 5 minutes, please.
Thank you. Actually, I'll just say, in the spirit of friendliness, could you answer Dr. Pawlowski's question?
And there's a lot there. I'm going to do my best to remember everything that came up there. So I think you were first speaking to the JAMA study, and you were talking about how they compared BC to Manitoba and Saskatchewan. Those drug supplies, those illicit drug supplies, are vastly different. In Ontario, the average amount of fentanyl in a piece of fentanyl is 5%. In BC, it is 16 to 20%. So BC is unique, and these are not directly comparable patient groups, because the fentanyl in BC is at least 4 times as strong as what people in Manitoba and Saskatchewan would be using. And so it's not unreasonable, I think it's very reasonable, to understand that when you have a more toxic supply in one one province, you're going to see a greater proportion of deaths than in a province where you have less of a toxic supply.
Thank you. I actually really appreciate that. Could you table with us any of that information so that we can have that
Absolutely.
as evidence?
Yes.
It's one thing that I just, one of the things as a mom, as someone that lives in a community that is impacted by addiction, like so many of us, it really scares me when people hear safe supply and they think that this is somehow now safe. And just like Dr. Pulowski mentioned about the fact that many of this was born out of the overprescription of opioids. And so this is now a marketing tool and a marketing term to call it safe supply. Would you consider using a different word?
So the term safe supply actually comes from the community of people who use drugs, and so we honor their participation in this, and we use the language that they would like us to use. And in terms of calling it safe, safer supply, managed opioids, whatever you choose to call it, all people who receive a prescribed safe supply are counseled extensively on the benefits and potential harms, potential risks, and that's part of a normal consent procedure. So we do...
Sorry, we just have very little time. So the studies that purport all the benefits of safe supply are based on questionnaires to patients that are prescribed safe supply. So is that not anecdotal?
It's not anecdotal. It's qualitative studies, which
Okay.
are highly prevalent in science and medicine, and certainly not unique to safe supply investigations.
So one thing I find kind of ironic is that after 8 years of the Liberals being in power and 8 years of your guys' clinic being open, it seems like the only thing in Canada that's cheaper is the price of hydromorphone tablets. In fact, Dr. Sharon Koivu said that hydromorphone dropped from about $20 a tablet in London to $2 a tablet. Does that not show that there is diversion clearly happening en masse in London?
Maybe, but maybe not. The price of fentanyl has also dropped dramatically. And back in 2016, when we started, a point of fentanyl was $40 to $50. A point of fentanyl is now maybe $10, often less. You can have Costco-size buys of fentanyl where people are getting, better deals for a larger volume. And so the prices of all drugs on the street
Does
have
that not
actually
terrify
declined.
you?
Yes, of course it does.
So why are you not doing more in your guys' clinic to prevent diversion from happening? Because there are so many, and I get that you're going to say that they're anecdotes, but there are so many stories that I have read specifically with your clinic with your name on it, pill bottles going out with hydromorphone that's being sold that people think are safe, and they might be coming from someone else. They might be coming from some big bad cartel that's making them and putting them into your pill bottles. It doesn't really matter. They are on the streets in London, and it has your name on it, and they're being sold to kids.
They're not being sold to kids. And so our diversion protocols in London are very, very robust. So
But
every
diversion is illegal.
Pardon me?
Diversion is
but I
illegal.
don't cause diversion. It is not my responsibility. Every single person who is seen in the Safe Supply Clinic receives a urine toxicology at every single visit. We monitor people very closely. Is it a perfect system? No, it's not. Just like methadone monitors through urine toxicology, it is not a perfect system either. But we intervene whenever there is any objective evidence of diversion. We meet with patients and we move them to observed models when we have objective evidence, and we
So
support
in-
people through that.
I appreciate that. In your guys' model, if someone does a urine test and it shows a drug other than hydromorphone, what does the conversation look like?
Our patients actually really welcome that feedback because what we do with people's urine toxicology is we actually summarize it. And so people, when they give a urine, they know that they're giving information to their community about what's present in the drug supply. So it helps us know what analogs people are from. And if your question is, do they continue to receive safe supply? Of course they do. Of course they do. Our intervention is meant to reduce or extinguish.
Thank you, Dr. Sarita. Well, unfortunately, the time is up in this round as well. Ms. Sidhu, you have the floor for 5 minutes, please.
Thank you, all the witnesses coming here. Thank you, Mr. Chair. Dr. Sarita, can you tell me how can we keep Canadians safe and about the importance of research and data-driven approach, so not based on the misinformation? Can you elaborate on that?
I think if I had that answer to that question, we may not be having half of the discussion that we're having today. How do I interrupt misinformation? I don't know. It's so much easier to spread mis and disinformation that it is actually able to rebut it with truth. It's very easy to make things up. It's more difficult to actually do the work of showing the truth of what's out there with research. Certainly our group and Safe Supply clinicians across the country are involved in robust and ongoing research generation, data generation and research. There are multiple studies ongoing about diversion because we know it is a concern that is being raised and we are studying it. But that science takes time. And to do really good quality research, it's not something that we can actually produce in weeks or months, but those studies are ongoing. And that's why it's hard to stay ahead of that misinformation campaign. Because again, I can make anything up and I can tweet it out or put it in the media. That takes, 10 minutes, half an hour. How long does it take to make something up? But to actually do the research, to show the truth on the ground, that takes time, that takes expertise, and that takes commitment, which all Safe Supply clinicians, including myself, including my program, are committed to.
You talked about the stigma. Stigma is a very real factor. But in this debate and in responding to the crisis, how's your opinion to combat stigma? Can you give a few examples to how the disclosure around the issue can further stigmatize those already suffering in the communities?
So I think in the two patient stories that I discussed near the beginning of this session, I think I highlighted to you how two women, one with HIV and actually what was considered a palliative AIDS, and another who was declined, heart valve replacement because she was a person who used drugs. That is stigma in action. Those two women were assumed by the medical system that they were going to die, that was going to be the outcome. Except when we intervened and actually provided an intervention that could stabilize their substance use, which was Safe Supply in those cases. Those women lived, they received their medical surgeries and medication for AIDS, and they are thriving and doing well. So in this instance, stigma almost killed these women, and stigma kills many more that our team doesn't hear about, isn't able to intervene with, doesn't get wind of. And those stories break my absolute heart because we hear them every day from our patients who have friends who went through it but didn't have a team to support them. The stigma, we're hearing so much about diversion today, and it's a critical issue that we discuss. But the premise behind many of these questions is that people who use drugs can't be trusted, that they're nefarious criminals who are looking to sell their medication to children and other people, who are looking to profiteer off the medications they're receiving. Starting that conversation with those assumptions, that's also stigma in action. And the stigma from our assumptions about drug users are limiting our ability to respond to this crisis in a timely manner. And it's limiting our ability to respond to this crisis with research-based evidence. And such as your first question, we're spending so much time responding to the disinformation campaign, it's taking away from our ability to provide that direct clinical care and that research that we need to do to save lives.
Can you expand on the importance of an integrated and wraparound model of care and addressing the social determinants of health? Specifically, how can this model engage more people who are ready for recovery?
Absolutely. And I think we've heard reference to the CMAJ paper a couple of times. I'd just like to reiterate that the CMAJ paper showing the 50% reduction in poor medical outcomes and 50% reduction in costs was from Safe Supply prescribing only prescribing. And so since then, we've been able to add the wraparound care. And from my experience, we are seeing people do so much better. There is a glass ceiling on how well I can make people when they are not housed. So we help them find housing. There is a glass ceiling when they're on social assistance and can't afford enough food to eat. So we provide people with food security. I could go on and on and on and on. And we are planning to actually repeat that study, looking at the impacts of wraparound care on people receiving Safe Supply, not just this prescription, but the entire program. And we have every expectation that that's going to show even better outcomes because we're seeing that every single day with the people that we serve.
Thank you very much, Ms. Sidhu and Dr. Sarita. The next round will go to Michel Thériault. Vous avez la parole pour 2 minutes et demie.
2.5 minutes, Mr. Thériault. In your presentation, Mr. Letellier Saint-Just, that prior to 2015-16, can you compare the two situations? Well, you can't criticize the then government in power from lacking. They wanted to tighten the law. They wanted to use a repressive approach. First of all, to impose minimum sentences, minimum maximum sentences, if you will. I remember the 2011 situation at the Insight location. I was a prosecutor in 2011 against. They refused to give the site an exemption to continue and allow it to continue. Well, we have dozens of sites now. So we exacerbated the crisis. I mean, it's a major flaw here. Harm reduction, that's the main reason. We depended far too much on criminalization, increased penalties. We filled our jails and prisons. The law that was adopted in 2002, there's an overrepresentation in our carceral institutions of first Indigenous people and racialized populations. So we imprisoned, we sanctioned people for infractions which were relatively minor and had no impact on public health. It's an archaic approach, and it's a false flag exercise. If you consult WHO, if you look at the UNDC, all stating we should go towards decriminalization, consider this a public health issue, not a criminal matter. So between 2005, 2015, very clear. Tightening the laws, making it tough on crime law. Do we have to go back to that? I hope not. I hope not. Thank you, Mr. Thériault.
Floor for 2.5 minutes.
You know, it's really good to hear everybody at the table say that there's no one size fits all in terms of responding to this. We know it's a complex issue, requires a comprehensive response. And I'm going to go back to the safer supply claims that have been made, because we saw BC with an overdose rate go up 5%. That's not good. Ontario, 6.8%. Two provinces that have safer supply programs. But we saw in Alberta, death rates went up 23%. Saskatchewan had gone down but jumped 32% last year. 30 U.S. states, from the numbers we have, 2019 to 21 doubled. Baltimore is 4 times the death rate of Vancouver. Philadelphia is double. Washington, Milwaukee, more, all without safe supply. So, Dr. Sereda, when you hear people point to safe supply as the cause for this crisis and driving death rates, and then you hear about the numbers in places that have no safe supply, maybe if you could speak to how this isn't factual and anecdotal comments are causing harm to communities, and take you've got 1 minute and 20 seconds, and you can add whatever you'd like to.
Yeah, it sets my brain on fire a bit, to be completely honest, because it is simply not possible for safe supply to be driving these deaths. It's not possible with the number of people receiving it compared to the number of people who use drugs and the number of people who are dying. And you're absolutely correct. In Canadian provinces that have robust harm reduction programming, not just safe supply, but robust harm reduction, we have seen less death in these provinces than in provinces that embrace an entirety of the entire spectrum of treatment approaches, like I mentioned in my opening remarks. And so when I see these other cities, my heart absolutely breaks, because that means there are 4 times as many families who don't have their loved ones anymore. It means there's 4 and 5 and 8 times as many, kids without their parents or parents without their kids. And I think we need, thank you.
What do you believe needs to happen? 1.8% of those that use substances on a daily basis in British Columbia, 225,000 are getting access to safer supply. What's the response that's necessary in this health crisis?
And so just to be clear, 225,000 are not receiving safe supply. 4,500 of 225,000 are receiving it. To get ahead of this crisis, I say the horse is just not out of the barn. It's all the way down the country laneway, and we're just chasing it and trying to get it back. We need...
I'm sorry, Dr. Sarita, I'm going to have to stop you there.
Okay,
but the good news, Mr. Johns, is because you have a benevolent chair, there will be 2 more rounds on the Conservative side, 2 more on the Liberal, and 1 more for each of you. So it's good news. Okay, moving on. Ms. Goodridge, you have the floor for 5.5 minutes. 5 minutes, I'm sorry.
I'd love 5.5, but thank you, Mr. Chair. Dr. Sarita, there were a series of letters that have come out in the last little while from some of Canada's leading addiction doctors sharing their concern around safer supply. So do you not take their words seriously?
Seriously. And first of all, they are self-described leading addiction physicians. And there's 30 people who signed that letter. There's also a letter was signed by 130 experts in substance use care supporting safe supply. And that letter gets a lot less attention, and we need to pay attention
Thank you.
to it.
I appreciate that. It's frustrating to me, and I also think disinformation is extremely damaging. The addiction crisis is incredibly troubling. In my home province, there are 5 addiction deaths a day. Like, this is not something small. This is not something I take lightly. I don't think that giving more drugs is somehow going to solve the problem. If that was the case, we wouldn't have anyone dying from alcoholism, and yet we have alcoholism leading in deaths across the country. So my question is going to be to Dr. Rob Tanguay. You talked about it in your opening statements around some of the OAT pieces. And so I was just wondering if you could explain to committee in a little bit more detail what OAT is and how Alberta goes around getting rapid access to OAT prescriptions for people struggling with addictions.
Yeah, thanks. I think that when we look at OAT is opioid agonist therapy. Other term for it is medication for opioid use disorder. We have guidelines based on massive studies. Guidelines suggest first line A is buprenorphine, naloxone. First line B and the gold standard being methadone. These are unfortunately not accessible to many Canadians around the country, which is really unfortunate. Access is everything, and getting access to these medications is key. Again, it's very important that that's with wraparound services. A molecule enough isn't about treatment. It's about stabilization. It's about initiating treatment. And that's really a big differentiating feature when we look at treatment of opioid use disorder. We talk about the use of buprenorphine or methadone or slow release oral morphine or whatever molecule we have. It's about stabilizing that individual so that we can work through some of the reasons that they're suffering with addiction. And that may include mental health. That may include trauma. There's a variety of reasons. That may include chronic pain. And I'm lucky to work with Maria on a lot of things as the co-chair for the Alberta Pain Strategy. But one thing is our virtual pain program works directly with our virtual opioid program to directly deal with these issues. But again, this is about medicalizing addiction as a health disorder, not about activism and other aspects. And the reality is following evidence is something that doesn't seem to be the focus here.
Appreciate that. And frankly, I'm a politician. I don't think that I should be the one setting the policy when it comes to these pieces. I really do believe we need to be listening to medical evidence and peer-reviewed evidence. And so at the end of this, we're going to have a report that's going to go back to Parliament. What would your recommendation be when it comes to opiate antagonist therapies, and perhaps having more access to them?
Yeah, well, there it is. It should be more access. I think we got to remember, we talked about the opioid crisis and how we got here. The reason we got here was because of diversion of prescribed opioids. It was the overprescribing, but the people who were being prescribed and taking the medication were never the problem. It was the fact, and as this was mentioned, it was family members, friends, or other reasons that people were diverting them. And then that led to the issues. Now, we heard about correlation versus causation. The correlation coefficient, which has been published on the amount of prescribed opioids and death, is 0.99. A perfect correlation, which we can cause causation, is 1. So we know the more we prescribe or the more access to a substance that can cause harm, the more danger from that substance. This is simple public health knowledge. Anybody who works in this area knows this, and this is why a lot of my colleagues are up in arms, is that it's not about the molecule. It's about the fact that we're not taking the time to prevent that molecule from being diverted and being harmed. Sorry.
Thank you, Dr. Tanguay. I appreciate that. Ms. Goodridge, thank you. Just so we're clear, Mr. Johari, Mr. Thériault, Mr. Johns, back to the Conservatives, and we'll finish off with the Liberals. So just so we're fair. Given that, Mr. Johari, you have the floor for 5 minutes, please.
Thank you, Mr. Chair, and I'd like to thank all witnesses for being so prepared and for the work that you do out there. I'd like to thank you all. Dr. Sereda, I'd like to start with you. You made a comment that if I wrote it down properly, I'd like you to expand on it. You said diversion is the symptom of unmet need in the community. And then on another response, you talked about that you'd really like to have the opportunity to talk about some of the diversion protocols that you have in your practice. Can you expand on what you mean by unmet need in the community, if I actually understood it correctly?
Yeah, so it is unmet need because of the limited capacity of safe supply programs to take in everyone who could benefit versus, like I said, the people who are not able to access. There can be a lot of translation between those two patient groups, if we can say that. And we know from the methadone literature that methadone is widely diverted because of that unmet need as well. And so when we read that methadone research, we know that people are distributing to their friends and their families who are in withdrawal, who may have just had an overdose, who are trying to get away from fentanyl. We know that clearly from that research. And that's what we see on the street level with people using safe supply as well. So people, again, will divert, and I would like to put air quotes around that, to their spouse who is in profound withdrawal. They may divert to their roommate who just had an overdose. These are out of care and compassion, and so I think it's really important that we be careful with the morality we're overlaying the word diversion. Does diversion mean, and when I say morality, does that mean people don't sell it? I'm not sitting here and saying that. I am saying that we are actually, we're not looking at it in its entire context because we stigmatize people who use drugs and we always assume that they're doing a bad thing when in the research shows that they are doing loving things for the people around them. And you asked me to expand on the diversion protocols. I did mention these with Ms. Goodridge. Like I said, every single person on my program receives a urine toxicology every single time they come in to see me, which for most of my patients is once per week. And so we monitor those urine toxicologies. We always do them sequentially because we know there is a false negative rate in those. And if we see people who do not have hydromorphone in their urine, our first step is actually to have a conversation with this patient because we have a long-term relationship. And within this, we say, do you have enough food to eat? Do you have a partner who is taking these medications? Are you at risk for violence, outside of pharmacy, as the Conservative MPs have alluded to here? We talk to them about the problems that they are experiencing, and we seek to fix those. And so, like I said, we provide food security, we can provide safety planning, we help, women leave partners when that is necessary, and the vast majority of the time, that solves the issue of what we're calling diversion. When it doesn't, okay, thank you.
Thank you. I want to go quickly to Dr. Tanguay. Dr. Tanguay, I also want to extend my condolences. Losing so many loved ones close and, friends and family members, it must be very hard on you. But thank you for the continued advocacy that you do. Dr. Tanguay, do I understand correctly that you say the prescription of safe supply, as I call it, should be used in the context of stabilizing the patient to a point that other needs of the patient could be addressed through the treatment? Am I right to understand that?
Yes, you're correct. All prescribing that we do in addiction is about stabilization of that individual so that we can move forward with treatment. But we also, as physicians, make sure that there's no harms to the community or others on our prescribing. For instance, urine on methadone. This is something that we do all the time, but we don't check for methadone. We check to see if they're using illicit substances. If they're not, then they get to start taking methadone home and not just be picking it up at the pharmacy. Not the opposite way of trusting.
Got 30 seconds. Thank you. But I want to come back to you again. How would that treatment look like? Because we're trying to come up with, at the end of the day, we're trying to come up with recommendations. And the recommendation around safe supply, how can it be managed? How could it be complemented? But I also wanted, if you could, in a little time that you have, talk about the treatment. How would treatment look like?
Yeah, it's a staged approach. I could do this all day long. So it would start with stabilization biologically and then moving into the psychosocial treatment aspect. It would include treating the underlying mental health conditions, treating the trauma, but it would also be looking at, workplace training, how to help someone look at returning back to the workplace, looking at a house. What does a house look like? So many of our people have never lived in a home that's been stable, never really appreciated that they can have. What treatment is all about is simple.
I'm sorry, Dr.
Our job is to create.
I'm going to stop you there. I apologize. As you said, maybe you could go on for days, but we don't have days. Monsieur Thériault, vous avez la parole pour 2 minutes et demie.
Mr. Thériault? Well, I would like Mr. Tanguay to continue on that line of thought. In your earlier presentation, you were speaking about self-management of the individual, that you would help them deal with his issue. Now, how do you go about that? How do you just don't hop into a detox program? What's your experience with this? Give us a success story, if you will, without having to institutionalize someone. Go ahead.
Stories of outpatients. I didn't really want to go down that road. I think the concept, I have patients who have gotten their jobs back, gotten their spouses back. Most importantly is when you help people get their children back. I mean, that's the biggest home run in my work, is seeing someone come in and introducing their children to you because you help them in their path to recovery. We talk about calling people. I've made many of those horrible calls. I've had tears on phones with moms and dads, brothers and sisters. At the same time, I've had tears of joys and hugs when we're discharging people and they're successful and they've been with us for years and they're showing us that they can and do recover. And it's about building hope. It's about believing that I can and if I want to, can move down the path to remitting my addiction, remitting my mental health disorder, getting my life back, and I deserve it.
Êtes-vous d'accord avec l'idée?
Do you agree with the notion that recidivism, is part of the process towards healing, towards recovery?
Yeah, so part of that is acceptance, and accepting that some of the decisions and aspects of being in a health disorder such as addiction has also led to issues, and I have to deal with those issues. I also believe that people do remit and relapse because it's a chronic, complex illness. And with that, we need access to supports, and we need communities of care and health and wellness. And that takes time. There's no easy answer to that, right?
Merci beaucoup, Mr. Thériault. Thank you, Dr. Tanguay. Mr. Johns, you have the floor for 2.5 minutes.
Well, first, I want to thank all of the witnesses for the important work they do in serving our communities. And I'm going to go back to you, Dr. Sereda. You got cut off a few times on yes or no answers, and I'm going to cede the next 2.5 minutes to you if you want to follow up with some of those responses that you weren't able to complete, and anything else you'd like to add.
I was really thinking hard about what I want to leave this committee with. And I think it's important that, our program, Safe Supply Clinicians, we see the deaths of so many people who cannot access Safe Supply because we still know them and we still care for them. And when these people die, Mr. Johns, we identify their bodies. As I said, we call their mothers, we plan their memorials, and we don't sleep because we don't know who is going to be dead in the morning. And the next day we get out of bed and we wipe our tears and we go back outside and we put our knees on the dirty pavement and we do CPR again and again and again. And we've been doing this for 8 years. 8 years. And I'm sorry, I used to keep a list of the dead on my office wall because I didn't want to forget them. But I ran out of paper, or I ran out of room to put that paper on my office wall, and I ran out of maybe the emotional fortitude to look at it every day. So I took it down and I put it away because it was too much. But even that empty space on the wall still says something to me. It tells me about the people we have not been able to save, and we cannot forget these people. We cannot forget these in the rhetorical discussions that we're seeing, in the misinformation. Those people are dead, and we're not getting them back. We have 42,000 dead. We lost 44,000 Canadians in World War II. In less than a year, we're going to lose more Canadians than we did in the entirety of World War II. So this crisis, it's producing mass death, and it's forever traumatizing those of us who care for them, their families and their communities, the frontline healthcare workers. We are working so hard to save every single life that we can. And so if I can leave this committee with anything, it's to rely on the actual scientific evidence and the expert evidence that is brought to you here, and not the media, and not misinformation, and not anecdotes, and not stigmatizing discourse. I want you to all picture that blank space on my office wall of the names I can no longer look at. Thank you.
Thank you very much, Dr. Sereda and Mr. Johns. We have 2 final rounds of questioning. Dr. Kitchen, you have the floor for 5 minutes.
Thank you, Mr. Chair, and thank you all for being here. It's much appreciated. It's interesting. It's not anecdotal that we are asking questions here today. We're asking questions because the people that are watching this, Canadians, want answers, because what's happening isn't helping. They want their children home, as Dr. Tanguay has indicated. They want to be able to see their children. They want to be able to see their family members, and they want to have them back the way they were. And that's the information we hear from our constituents who continually portray that to us. As much as you might want to call it anecdotal, it is our constituents around this table that are telling us this information. But with that said, Dr. Tanguay, you had some great comments, and I do have a question for you, and a number for you. You mentioned about the lifetime prevalence of TBI and suggesting that there's an increased incidence of drug use because of that. Can you elaborate on that, please?
Sorry, just to be clear, that's the lifetime prevalence of people living without homes in traumatic brain injuries being that high. Looking at moderate to severe, 10% of all brain injuries are because of overdoses that are occurring on our streets. And that's just published in the peer-reviewed literature. That's just pure data that's been published and looked upon. And it talks about just how severe our vulnerable populations are.
Thank you. I appreciate that because I know a 16-year-old boy who was the victim of a hit and run, went headfirst through front windshield of a vehicle, had brain matter draining out his left ear, is deaf in his left ear, multiple broken bones, multiple injuries to his face, etc. And definitely concerns that in many times in his life as to where that could take him to. And with that said, that happened to me, and I'm that boy, and it happened 50 years ago, this May. And fortunately, to many aspects of people that helped out along those lines, ultimately, I want to talk to Ms. Hudspeth. You talk about the Pain Task Force, and I fortunately, through my career, put myself through education and sports to get myself to where I am today. And my time I spent at Royal University Hospital in Saskatoon, I was with Professor Emeritus Gordon Wyatt, who is an anesthesiologist in pain and started the pain clinic at the U of S. And one of the things he talked about is exactly what you pointed out, which is the three things with pharma, psychology, and physical, and all those aspects of it. And I'm just wondering if you would comment a little bit more on that, please.
Thank you for the question. I think this is one of the pieces where, as Rob is saying, safe supply needs to include all these other pieces. So providing a medication is one thing. We know that people need other aspects of pain control. So we've talked a lot about the issue of overprescribing of opioids leading us for pain, leading us here. And we know that we cannot just prescribe our way out of this problem. We need to be providing wraparound services, mental health services, addiction services, and pain services for people who are at risk of overdose. I'm particularly concerned about the population of people who have been on long-term opioids for pain, who are being deprescribed and are at risk of overdose. They are not meeting the criteria for safe supply.
Thank you for that. Appreciate that. Ultimately, what we see and what I alluded to earlier is that the people that are watching this aren't the addicts that are watching us here today. They aren't the ones watching this, what's going on. It's the parents. It's the family that are watching and the conversations we've had. And I had a conversation, in fact, just 2 days ago with a constituent of mine who, in our conversation, was talking about her son who's addicted and how he gets arrested, and the police have been very helpful to her, but he can't get the treatment. He can't get what he needs because he can't get into the treatment centers, and he's finally recognized that he needs that aspect of it, and to the point where we are having our conversation, and he was screaming at me over the phone because of what was going on and his mother doing this. And these are huge challenges. How do we get people? Those are steps that we need. I think you're all alluding to it, but we need to get first health care to our constituents right from the get-go and the start. And I'm wondering, for Dr. Tanguay, if you have any suggestions, what can we do differently to improve that?
Dr. Tanguay, if you can tell us that in 15 seconds or less, that would be terrific.
15 seconds. Well, we have to take a good look at the Canada Health Act. The Canada Health Act does not support or include interdisciplinary care for those who need it the most. It does not include care for chronic complex illness. It doesn't include physiotherapy. It doesn't include psychology. It doesn't include occupational therapy. It doesn't include all of our allied health. The provinces do this out of their own decisions and will. It is not covered under our Canada Health Act. And so, quite simply, everything we want to do, we can't because our Health Care Act doesn't allow us to.
Thank you very much, Dr. Tanguay. Thank you, Dr. Kitchen. The final word will go to you, to Dr. Hanley. You have the floor for 5 minutes.
And thanks again to all of you for your really valuable contributions. I'm going to try and keep this short for each of you. Ms. Hudspeth, I probably won't actually ask your question, but we did leave a question unanswered, and I'm wondering whether you'd be able to submit some written answers, and that was around the role of pain care in public health, in the public healthcare system, and also the role of self-management and the work you've been doing in that regard. Dr. Tanguay, again, thanks so much for your really helpful testimony. I know it's not a quick question, but I'm going to make it a quick question. Getting oat into rural communities, can you maybe talk about the importance of that and how we can best leverage that in 30 seconds or less?
Absolutely. Virtual care is absolutely paramount to this. A virtual look, we live in Canada. We know there's health disparities, and we know part of that health disparity includes where you live. And if you live in rural, where I'm from, rural, small town, southern Alberta and northern Alberta previously, where you have to drive hours just to see a doctor. Virtual care is a way of absolutely closing that gap and making it simplistic. Then, of course, working with your pharmacies. Look, most pharmacies, when I started treatment and fentanyl came in a green bean that was a shady 80 or a fake oxycodone 80, it was never anything else. And that's when the cookie kind of thing actually made sense. We couldn't get a pharmacist to prescribe Suboxone outside of a very specific one. Now you can go to Safeway, you can go to Superstore, you can go to, I'm going to get in trouble for naming companies, but
I'm going to
you can
cut you
go
off,
anywhere.
Dr. Tanguay, but anything else that you could supply written would be greatly valuable. One thing, since we're focused on really the federal government's response, can you tell me one thing that we should be doing more as a federal government, that we could be doing more to address the scale of this crisis?
Yeah, it's time for us to really step up and decide, are we going to take care of our most vulnerable or not? And that means looking at the Canada Health Act and deciding, are we going to cover interdisciplinary care or not? And it's time to really take a look at that aspect, that if we're going to cover interdisciplinary care, and that means taking care of our most vulnerable in their complex and difficult illnesses, this is the way we're going to do it, so they don't have to access small centers of excellence that are almost completely inaccessible.
Thank you very much. Dr. Sereda, I'm going to bring the question to you. I think what I've heard is that there's far more in common between the testimony that we've heard from all of the witnesses about the spectrum of approaches that we need. We also know that that with the number of Canadians that are dying every day, we need to do much more. So as a country, are we responding at the scale that we need to? If not, you did mention waiting for SUAP approvals, but what else? What are other actions, concrete actions, should we be doing as a federal government?
So you mentioned agreement. I think it's important that we rapidly, emergently scale up all of the scope of the spectrum of interventions that people need to survive this crisis. So I've been asked a lot of questions about safe supply today. Obviously, I think there's many Canadians who could be kept alive with that approach, but we also need to rapidly scale up access to conventional addiction medications like methadone and buprenorphine. We need to scale up access to treatment on demand through bed-based treatment if that is what people desire. And also as a country, what do we need to do now? We need to stop blaming the people who are dying for the fact that they are dying. We need to stop stigmatizing people who use drugs, because that is directly impairing any kind of response that we can have on any kind of emergency timeline. So we need to lay all of that stigma behind us, the marginalization behind us, and really focus on saving lives.
Thank you. And I might have a few more seconds. Can you briefly distinguish for us the difference between anecdote and qualitative research? You did highlight that briefly.
Thank you. So qualitative research is done by experienced academics and researchers who have been trained in qualitative methodologies. These things go through ethic review panels. The methodologies are examined and they're closely, followed. Whereas anecdote is different. Anecdote is asking one person what happened and not putting that under any kind of critical appraisal, not going through any kind of ethics review to see the impact on the community or the person of that information that you're seeking. It doesn't go through any kind of peer review, which all qualitative research does. And so anecdote just stands alone as someone's statement. Qualitative research has a long-standing history of quality and describing people's experiences in healthcare.
Thank you. Thank you very much, Dr. Hanley, and thank you to all the witnesses for taking the time to appear and share such valuable information with us today. I know it'll be important to our analysts as we create a report for the Canadian public as we go forward. Our next meeting will be Thursday, February 29th, again, continuing on the opioid epidemic and toxic drug crisis in Canada, so I look forward to that as well. We've given you a bit of extra time since we started late, so is it the will of the committee to adjourn? Yes, sir. Seeing general agreement, it is. Meeting adjourned.